As you will see, these cases of endophthalmitis differ completely in microbiology and the prognosis compared to post-cataract endophthalmitis or to post-injection endophthalmitis. So, blebitis. We shall start with bleb-associated endophthalmitis. We have something called blebitis, when the infection is limited to the bleb and the vitreous is still clear. So, meaning that it is a localized infection to the bleb and it did not progress yet to involve the vitreous. So there is infection in or around the filtering bleb without vitreous involvement, but you can have mild to moderate anterior chamber inflammation. This is an emergency. And what is endophthalmitis? Bleb-associated endophthalmitis. You have bleb infection with vitreous involvement if the patient comes late. And this bleb-associated endophthalmitis can develop months or years after surgery. Like I managed recently a patient with bleb-associated endophthalmitis, and he presented like 6 years after having glaucoma surgery. There are two types of bleb-associated endophthalmitis. There is an acute type or early onset that like cataract. If you do cataract surgery, you can have organisms, mainly coagulase negative cocci, that will enter into the eye through the conjunctival flora. The same with glaucoma, if you open the globe. So acute endophthalmitis can happen before 1 month after surgery, but meaning that the inoculation occurred during the surgery. أنا شايف إن كل 2 من الزميلات قاعدين بيتحدثوا مع بعض. دكتورة لو في موضوع مهم يا يتأجل ممكن تكملوا بره، لكن ما ينفعش أثناء المحاضرة إن أنتوا قاعدين بتتكلموا. في بره كافتيريا، لو الموضوع مهم تكملوه في الكافتيريا، بس بدنا قاعدة في المحاضرة تسمع المحاضرة. So in this condition, the acute bleb endophthalmitis, which organism you would expect? Gram positive, coagulase negative, staphylococci, mostly staph epidermidis, right? Because it's like cataract. But the ones that can develop more than a month and even years after surgery is different. If you look at the incidence of bleb-associated endophthalmitis, it is higher than most other in intraocular procedures, much higher than after cataract. They reported to occur after 0.2% to 9.6% of glaucoma filtering procedures. And the incidence increases with the use of antifibrotic agents. There's marked increase after the use of antifibrotic agents that will induce thin, cystic, avascular bleb that may be vulnerable to infection or leakage. The yearly incidence is estimated to be 2.1% to 2.6% with mitomycin C, and 1.7% was 5-fluorouracil. What are the risk factors? Inferior bleb has been shown to increase the risk of bleb-associated endophthalmitis. Thin bleb leak. If a patient had a bleb leak, it should be fixed immediately because this can cause endophthalmitis. Antifibrotic agents, post-operative complications such as flat anterior chamber, early wound leak, suprachoroidal hemorrhage. Other risk factor, patient had prior conjunctivitis, upper respiratory tract infection, blepharitis, history of bleb infection, chronic use of antibiotics. These are all risk factors that we need to look at. So if you have a patient with a leaking bleb, don't discharge the patient. You have to fix it. Now, what is the microbiology? As we discussed, The early onset cases that develop within days after the surgery, this is mostly caused by coagulase negative staphylococci, mainly Staph epidermidis, because this is coming from the conjunctival flora. Same like cataract. But how about the late onset? That can develop up to 20 years. The microbiology is different. Streptococcus species, Haemophilus influenza, these are the most virulent. They produce exotoxins that can penetrate intact conjunctiva. And this is a problem. That is why the prognosis is not good. Symptoms, of course, red eye, pain, photophobia, like any infection. The signs. This is a classic case of bleb-associated endophthalmitis. You can see the turbid fluid in the bleb, corneal edema, and severe vitritis. So this patient, I still remember her, she presented like more than 10 years after having glaucoma surgery. But she was seen by an ophthalmologist before she came to our emergency room, who gave her antibiotic drops. So education is important. We need to educate ophthalmologists, because he missed that the patient had blebitis, because she originally presented to this ophthalmologist with blebitis. But he only gave her antibiotic drops and discharged her. So she came, in fact, her eye was lost. She had a Streptococcus species, endophthalmitis. So the workup, slit lamp by microscopy, you have to look for leak, ultrasound and B-scan, microbiologic procedures. You need to do conjunctival swab over the bleb, and two-chamber tab and vitreous tab. What's the treatment? If you diagnose the case as blebitis, and what is the difference between now blebitis and endophthalmitis? Endophthalmitis means vitreous involvement. If the vitreous involved, this is endophthalmitis. But in blebitis, if the vitreous is still clear, this is blebitis. You need to give the patient intensive topical antibiotics, fortified antibiotic drops hourly, like vancomycin and tobramycin. You can give topical steroids 24 hours after antibiotics. How about the late onset bleb-associated endophthalmitis? How should we treat these cases? First of all, you cannot apply the endophthalmitis vitrectomy study guidelines to these cases. Why? Because the endophthalmitis guideline says that if the vision is hand motion or better, don't do vitrectomy. If the vision is only light perception, this is after cataract surgery, you do vitrectomy. Can you apply these guidelines to these cases? Why? Different microbiology and different outcome and different severity. In cataract endophthalmitis, we are talking about disease, 70% of the cases are caused by less virulent bacteria, coagulase negative staphylococcus. But here, we are talking about a disease, majority of the bacteria are aggressive, virulent. So these cases, they need more aggressive treatment. They need prompt vitrectomy, very early vitrectomy, and intravitreal antibiotics, of course, the combination with vanco and ceftazidime. Now, there's a special type of endophthalmitis that develop in patients that had glaucoma drainage devices, tube surgery. And again, the risk in this case is persist for years. The risk factors are exposure of the tube or plate. This is an important risk factor. I have seen cases like this. The plate is exposed, not covered by conjunctiva. So you need to cover the exposed device immediately to minimize the risk. And if there's endophthalmitis, you need to remove the device with vitrectomy. So what is the prognosis for this infection? If it is pure blebitis, in our experience, excellent prognosis. We admit the patient, hourly 45 drops, and then later on we add steroids. For bleb-associated endophthalmitis, unfortunately, the prognosis is still poor visual prognosis, even with aggressive medical and surgical intervention. Why? Because we are dealing with a disease caused by more virulent organisms capable of penetrating intact blebs with rapid spread into antechamber and vitreous. I summarize here two studies that show that only 10 to 13% of the patients achieved 20, 40 or better vision. And majority of the patients, the eyes were eviscerated. Compare this with the post-cataract endophthalmitis. In the endophthalmitis vitrectomy study, which is examined only patients after cataract-related endophthalmitis, 53% of the patients achieved 20, 40 or better visual acuity. Big difference. And the main reason for this is different microbiology. In post-cataract endophthalmitis, 70% of the cases are caused by less virulent organism. Here, the majority of the cases are caused by very aggressive organism. If you remember last week, I said that 9% of the cases of post-cataract endophthalmitis are caused by Streptococcus. And these 9% cases are the cases that the eyes are lost. So how would we prevent this? We have to check for leaks. And if you diagnose leaking bleb, you have to close it. Risk factors such as chronic blepharitis need to be treated. You have to educate the patient. As the patient, they have to report to the emergency room if they have a red eye or pain, because early diagnosis will help. So this is regarding bleb-associated endophthalmitis. Now I'm going to talk now about post-traumatic endophthalmitis. And for many years, I had a lot of interest in the prevention of post-traumatic endophthalmitis, and that we shall discuss it now. So it is a devastating complication of open globe injury. It has its own subset of microbiology. Unfortunately, the visual outcome is still poor despite advances in vitreoretinal techniques and intraocular antibiotic use. Therefore, a lot of emphasis has to be put on prevention or prophylaxis. And post-traumatic endophthalmitis accounts for about 25% of all endophthalmitis cases. Looking at the incidence, I put a summary here of most important studies. Some of them are old. And you can see that the incidence ranges between, based on the study, from 4% up to 17%. Very high compared to cataract endophthalmitis. So these patients who have open globe injury are at high risk to develop endophthalmitis. And this is the summary of studies that looked at specifically at intraocular foreign bodies. Again, you can see ranges between 4.5% to 10%. So presence of an intraocular foreign body, one study, very elegant study, they cultured the foreign body after being removed from the eye using vitrectomy techniques. They cultured the foreign body, and they found that 26% of these foreign bodies, by culturing them, they grow bacteria. That means that these foreign bodies are contaminated. What does this mean? We need to remove this foreign body early. Now, there are several studies that compared the incidence of endophthalmitis in eyes with or without foreign body. So in one study, about 11% with intraocular foreign bodies had endophthalmitis compared to 5% without foreign body, meaning that presence of a foreign body doubles the risk of endophthalmitis. Another study, 5.6% with foreign body compared to 3%. Another study, 10% with foreign body compared to 5%. So this is another important point to keep in mind, that the presence of an intraocular foreign body increases the risk. Another study showed 4 times increased the incidence of infection for eyes with intraocular foreign body if primary repair and the removal of the foreign body is delayed more than 24 hours. This again another risk factor for traumatic endophthalmitis, delaying the primary repair. But this study showed that eyes with foreign body, if you delay the closing the globe and removal of the foreign body more than 24 hours after injury, this increases the risk, and this is 13.4% versus 3.5%. Another risk factor, which is very important, and we have in our study, we showed this, disruption of the crystalline lens. If a patient comes with open globe injury and the lens capsule is opened, and it is a risk factor. Of course, severity of injury and lens disruption. One of the most important risk factors is trauma in a farm, or rural trauma. A patient who is working in a farm and had open globe injury, the risk is extremely high. This is a very famous paper that looked at rural trauma, and the incidence was 30% after rural trauma compared to 11% after non-rural trauma. Another risk factor was initiation of prophylactic intravenous antibiotics later than 24 hours after trauma. Another risk factor was failure to use prophylactic antibiotics, either systemically or intravitreally. Now, this study was a nice study that they did both univariate analysis and the multivariate analysis to identify the risk factors for why it is important to discuss risk factors so that we know how to prevent the disease. So on univariate analysis, the risk factors were dirty wound. If a patient comes with a dirty wound, it's an important risk factor. Retained intraocular foreign body, ruptured lens capsule, delayed primary repair more than 12 hours, and rural address. On multivariate analysis, it showed that the strongest risk factors were still dirty wound, ruptured lens capsule, and delayed primary repair. So these are risk factors for infection, meaning that these patients, they need particular attention when it comes to prophylaxis. And that's why in our department, many years ago, after we published the first pair of risk factors, after we identified the risk factors for infection in open globe injury, we started a new protocol that high-risk patients, we give them intravitreal antibiotics at the time of the primary repair. So clinical diagnosis, again, requires a high index of suspicion, meaning that you admitted the patient, you repaired the globe, and next day you notice that the patient had inflammation more than expected. You have to treat this patient as a case of endophthalmitis. The signs and symptoms are the same like endophthalmitis. This is an example of a patient who had hypopyon, severe vitritis, pseudocyanea. This is a paper that we did several years ago in collaboration with Kikash. I think our friend Ahmed was among the authors. So we looked at the microbiology of traumatic endophthalmitis in our region, in our patients. And this is our study, current study. We had 67 patients with post-traumatic endophthalmitis. We compared them with previously published 17 studies. And these 17 studies including about 400 patients. So look here. Staph coagulase negative cocci in our study accounted for 25%, previous study 21%. This organism accounted for how many of the post-cataract? 70. So here, much less. But Streptococcus species in our study accounted for 26%, in previous studies 14%. And the Streptococcus species in the post-cataract, 9%. So here we have more virulent organism. And also we have here more of a mixed infections. I had several patients, the culture grew several organisms. So mixed infection in our study was 12%, previous study 16%. But luckily, there is a very aggressive organism called Bacillus species. It destroys the eye in hours. In studies from other geographic regions, it accounted for 18%. This is well known in America and in this, Europe. In our study, only 3%. So we don't have such a high incidence of bacillus like other studies. And I still remember that one reviewer asked us, how would you explain this? How you explain why we don't have high incidence of traumatic endophthalmitis caused by bacillus compared to other countries? And the answer was very easy, because bacillus, they tend to form spores in the soil. And these spores can be killed by heat. So it seems that because we have here temperature is higher, that these spores cannot survive. So we don't have bacillus endophthalmitis as frequent as in other countries. And this is a summary of these 17 studies that I compared with our data. And then we also looked at intraocular foreign body endophthalmitis. With intraocular foreign body, again, coagulase negative cocci 34%, bacillus species only 3.4%, but previous studies from other geographic regions 33%. That was the first study that looked in detail to the microbiology of traumatic endophthalmitis. So to summarize the microbiology of traumatic endophthalmitis, coagulase negative staphylococci endophthalmitis after trauma is less frequent than after cataract surgery, and this explains the outcome. Coagulase negative staphylococci, as I said, predominant staph epidermidis account for 70% of endophthalmitis after cataract surgery. The rate of isolation of Streptococcus species in post-traumatic endophthalmitis is higher than 9% rate found in endophthalmitis after cataract surgery. In endophthalmitis after cataract surgery, Streptococcus species was associated with the poorest visual prognosis. So when we talk about prognosis in post-traumatic endophthalmitis, in general, the prognosis is poor. And why the prognosis is poor? Because there is usually delay in diagnosis and treatment. I have seen cases that the treating physician, after repairing the globe, and he sees next day inflammation, he thinks that this inflammation is related to the trauma. And then when I'm consulted 3-4 days later, it's endophthalmitis. So for us, if we repair an open globe injury and we see that the inflammation is more than expected, you have to treat the case as endophthalmitis. So there is always this problem. The physician doesn't know if this inflammation due to trauma or due to infection. But if the inflammation is more than expected, you have to treat as infection. So there is delay in diagnosis and the treatment. Of course, associated ocular injuries. The organisms are virulent. Polymicrobial infection, mixed infection, and of course, associated inflammation. When we combined this, in this study, we did a lot of work. When we combined the previously reported studies, visual acuities of 2400 or better were preserved in only 37% of the patient. You're talking about 2400 or better. Only 37% of the patient. This is in the previous studies. In our study, we were able to preserve vision of 2200 or better in about 50% of the patients. How about prophylaxis? Now we know that the risk is very high, so we should have a clear idea about prophylaxis. And this is a very nice study, although it's old study, that they took aqueous sample at the time of repair of the open globe injury, and they cultured. And they found that if you give the patient intravenous antibiotics before the wound repair, this significantly reduces culture positive of the aqueous humor at the time of surgery. This study showed, the first study to show the importance of prophylactic intravenous antibiotics in reducing the contamination of the anterior chamber. And so this study supported the prophylactic use of broad-spectrum intravenous antibiotics against the development of endophthalmitis by reducing the incidence of intraocular microbial contamination. Then, now we know that intravenous antibiotics are important. Which antibiotics? We, for years, because we are dealing with an eye that is potentially infected, we use a combination of intravenous vancomycin with ceftazidime. Both of these antibiotics have good penetration into the eye, especially in traumatized eyes. Then this is a paper that we published several years ago on risk factors for culture-positive endophthalmitis after repair of open globe injuries. And in this study, I'm trying to magnify this, the incidence of endophthalmitis was 1.9%. So all these patients received intravenous prophylactic antibiotics. This is our protocol at King Abdulaziz University Hospital. Any patient with open globe injury is treated with intravenous antibiotics, vancomycin and ceftazidime. And so our incidence here was 1.9%, which is much lower than other. So because the incidence of culture-positive endophthalmitis in our study was 1.9%, and in this study, we reviewed the files, thanks to Dr. Hani al-Mizani, who did a lot of work at that time, of almost 630 patients with open globe injury. So you remember in my introduction, the incidence of traumatic endophthalmitis can be as high as 17% after open globe injury. In our study, we have only 2%. This might be the result of the routine prophylactic use of intravenous antibiotics. And then during writing the paper, there was another paper that also documented low incidence of endophthalmitis, and they attributed this to the use of intravenous intravenous vancomycin and ceftazidime. That means that prophylactic use of these two antibiotics that provide broad coverage is useful to reduce the risk of endophthalmitis. So as related to prophylaxis, as I said, an important risk factor is delaying the repair. So prompt vitrectomy and removal of acute retained intraocular foam body is important. Delay in primary repair of ruptured globe of more than 24 hours cause 4 times risk of increased incidence of endophthalmitis in eyes with intraocular foam body. In another study, delay in the primary repair more than 12 hours was associated with the development of endophthalmitis. Now, the big issue that we really started at King Abdul University Hospital is prophylactic intravitreal antibiotics. So the high-risk cases, we had now a new protocol in the hospital that we identified high-risk cases based on our analysis. Our analysis shows that high-risk cases, if an injured eye had, this is from another study, but we had more or less the same, had 2 or more of 3 risk factors: delay in primary repair more than 24 hours, dirty wound, lens trauma, then the relative risk of developing endophthalmitis is 5 times. So these patients should receive prophylactic antibiotics. So intravitreal antibiotic, you remember I told you that one of the important risk factors is trauma in a rural setting, in a farm. So this is an important indication. Presence of an intraocular foam body contaminated with organic material or soil. So we published a paper that the title of the paper is that prophylactic intravitreal antibiotics reduce the risk of post-traumatic endophthalmitis after repair of open globe injury. So that was a paper based on a very large number of patients that we showed that, but our protocol we don't give for all patients. We gave it only for high-risk patients according to the risk factors that we discussed. So the management of a post-traumatic endophthalmitis, we prefer, and as I said, because of the aggressive nature of the bacteria causing traumatic endophthalmitis, prompt vitrectomy will be important. And of course, intravitreal antibiotics, and the combination we always use is vancomycin and ceftazidime. You can use corticosteroids. So primary barzibulin vitrectomy is recommended because of the virulent nature of the organism and even multiple organisms. And this disease represents a very different clinical situation, different from that of the endophthalmitis vitrectomy studies that dealt only with post-cataract endophthalmitis. So as I said earlier, you cannot apply the guidelines of the endophthalmitis vitrectomy study to traumatic endophthalmitis or bleb-associated endophthalmitis. As I said, in the endophthalmitis vitrectomy study that included only post-cataract endophthalmitis, infection with a species other than gram-positive coagulase negative staphylococci was significantly associated with poor visual prognosis. This is an example of a case of traumatic endophthalmitis that we did vitrectomy many years ago, and look at this, the organisms: Streptococcus pneumonia, Streptococcus sanguis, and Moraxella catarrhalis. So as I said, up to 17% of the patient, particularly with foreign bodies, they can have mixed infection. So conclusion, because of the substantial incidence of endophthalmitis after penetrating trauma, emphasis should be placed on prophylaxis. High index of suspicion for infection in the setting of trauma. I'm going to repeat it again. You repair open globe injury, next day you found that the patient had inflammation more than expected, you should treat the patient as endophthalmitis. Never attribute, the inflammation might be related to trauma, but if the inflammation is more than expected, you have to treat the patient as endophthalmitis. Early diagnosis and the prompt institution of effective antimicrobial therapy. Proceed with cultures and the treatment in eyes suspected of having endophthalmitis. The complications of cultures and the treatment in sterile eyes are outweighed by the devastating results of delaying treatment of infected eyes. If a period of observation, if you need a period of observation, this should be hours, but not days. So due to the devastating outcome, post-traumatic endophthalmitis should be treated promptly with vitrectomy and intravitreal antibiotics. You can use also steroids. Thank you very much for your attention.